Well, it's a real honor to introduce Richard Westmark as our invited speaker. Today, he's here with his lovely wife, Kay, and they traveled here from Houston, Texas. And Richard and I have known each other for 25 plus years and knows many of the people in the department, including Dr. Green, Dr. Harros, Dr. Marcos. Richard did his neurosurgery residency at the Mass General. That's where he met up with people like Roberto and Nino, and ended up doing a fellowship with Volker Sonntag, I think in 1995 at the BNI. I think it was the year before myself and John Hurlbert went there, and then went into practice in neurosurgery, and that's a lot of the neurosurgical part of things, but he's going to be talking to us about finances, and he is extraordinarily qualified to do that because Richard, and he'll tell you, became interested in that world very, very early on. And as his career has matured, it's taken a bigger bite of his time, I would tell you. And I'm not going to get into the details. I'll let him get into the details of what he does on a daily basis, but extraordinarily impressive founder and CEO of a hedge fund. And we started talking about him coming down here to give us a talk after the talk that Dan, and hopefully Dan's on the phone or on Zoom, and if he is, I want to congratulate him and his wife for having a baby last Monday. We're all super excited for him, and we can't wait to see the pictures. But Dan gave a phenomenal talk on finances, and this is that was 101, and this is going to be finances 103. So Richard, thank you for coming. Really appreciate it.
Well, thank you for that, Alan. And I can't tell you how much I love looking up there and seeing all you people. And so it's an honor for me to be talking this morning. And the idea to give this talk is that we as neurosurgeons, as doctors, get to do things that nobody else gets to do. And as someone who's transitioned into it almost exclusively business world, there's nothing that brings in my memory things as honorable and pleasurable as being a neurosurgeon and being a doctor and helping other people. I'll walk you through the thought process, but the overall picture of this is that I would not recommend you take my path. If anybody in the room wants to take my path, please, I'm hiring, but I wouldn't recommend it. I think that what you get to do this incredible thing. And so what my hope is that I can use some of my experience to maybe guide you all in a way that lets you enjoy some of the financial benefits of being secure and how that might impact your ability to be really, really great doctors. And so that's the title of the talk, is the impact of physician financial stewardship on patient care for that reason. And so the goals of the talk, the first is that I'm not giving any financial advice to anybody. I am SEC and FINRA regulated. It's illegal. I cannot give financial advice, so I'm not doing that. Anything I say will be things that are my opinions of how one might in some kind of empirical way secure your future. I'd like to try as best as I can to get doctors, you all, to kind of not think that money is bad or thinking about money is unethical or bad. And indeed, in my opinion, in order to not think about money, you have to think about money. And so I'd like to move the talk from doctors kind of ignoring money to actually embracing it. This is not an early retirement plan. I guess you guys probably know what FIRE is. I don't know if you guys know what FIRE is. It's financial independence, retire early. It's a big move. People want to retire at 30. Retiring at 30 sounds like a horrible idea. Most of you guys won't start practice before then. Yeah. So And so the goal is to have a financial strategy in place that, and this is for everybody in the room, including you, Dr. Green, that goes on self-control. So you don't have to continuously do this while you're trying to work and practice medicine. So why me? And Alan commented on that. And the reason that I put this slide in is because I see a lot of the initiatives in the AANS and the Congress, in fact, all throughout medicine. You have practicing doctors who give talks about financial things. And quite frankly, I'm not even sure where their information comes from, but they do this. I've taken a completely different path. This isn't a late life change for me. I traded my first stock in 1974. For you all, that's way before you were born. I have an economics degree. I was raised by a businessman to be a businessman. I created Westmark Enterprises about 30 years ago. We're a multi-asset manager all over the world. We have most of our assets are in Europe and in the United States. It's across every platform you can think of: private equity, venture capital. We develop real estate and public equities. About 25 years ago, I realized that our public equity portfolio was not performing. And I created an algorithm, or started working on an algorithm that now is the basis for my hedge fund, which I launched 3 years ago. So as I think about looking back at medicine and the finances of medicine, I would encourage everyone to realize that each and every one of us are entrepreneurs. And you don't think of yourself that way. You think of yourself as a doctor, but you're actually an entrepreneur. And I say you sell widgets because, in business school, that's every analogy is to widgets. And I like it because it kind of removes you from the patient care aspect of it. The widgets you sell are office visits and surgery. And it's true, whether you think of it that way or not, you're selling widgets. And there's good news and bad news about the widgets that we choose to sell. Here's the good news. The good news is you make more money than everybody else. And I hear doctors, say, well, I could have gone in business and done this or done that. It's a dog-eat-dog world out there in the business world. It's really hard to make a living. Doctors are essentially guaranteed a higher salary than virtually every other profession. This is from the US Bureau of Labor Statistics. You'll see all different numbers, but this is from them. So here's the bad news. So remember, the good news is you have income and you have disposable income. The bad news is this. So what you see in this graph is the bottom here. This is wages over your lifetime. And you can see you're late to having the wages. You plateau really, really quickly and abruptly. Most business careers go like this and peak at about 60. And you can see by 60, you're already falling off on the wage curve. This actually, the upper curve is for private practice. These are people who have captured some of that patient-generated revenue from whatever it is that they're doing. And you can see that's a buffer against it. If you're an employed physician or an academic physician, your bosses recognize that, and they will bump up your wages to compensate for that. So bad news is you're late to it, you peak early, and you fall off fast, and of course you have student debt. So that's the bad news, and here's the really bad news. So what you're looking at here, that the purple line, there we go. So the purple line is the CPI, or the inflation rate. These are practice costs, which are keeping just about up with inflation, but this is physician pay, and this is over 20 years. This is annualized, this is absolute. So you can see in nominal terms, non-inflation adjusted terms, over 20 years total up 10. And it's really 8% without the non-recurring COVID bump that you see there at the end. But you're actually down, real pay is down 20% over 20 years. It's hard to find an industry where you see a curve like that. So your costs are going up and your wages are going down. So you're getting hurt on both sides of the inflation curve. And you can see that the hospitals have figured out a way to outpace inflation. So what do you do? So here you are. You make a lot of money. You don't make it for long, and you're up against horrible pricing. So the thing that the normal model for doctors to do is to sell more widgets. And what that means is you go in and you see more patients in clinic, you do more surgery, and you get on this treadmill of generating RVUs and selling more widgets. Obviously, that's got a lot of impact. It's got a lot of impact on patient care. It's got a lot of impact on your families, your health, and importantly to me, other things that you might want to do, whether it be, you know, charitable work or traveling to Africa, and whatever it is that you might want in your mission statement. So personally, I think that's a bad idea to sell more widgets, but I think that's the normal doctor methodology. And it's exhausting, and I would argue it leads to a lot of physician burnout. So the alternative is to diversify your income stream. And so you want to reduce your reliance on making and selling widgets. You want to strengthen your personal balance sheet, which is the ultimate goal, which I'll tell you is this simple strategy. And you want to deploy this excess capital. Remember, you're making more money than most people. You want to deploy it efficiently and not make bad decisions that are commonly known as dumb doctor deals. You can horizontally integrate. That would be mostly in private practice, that you can do these other things. But I will tell you that academic centers, employed physicians are having more and more access to ambulatory surgery center ownership. It's a little jewel that they're offering across many platforms. So I hopefully have given you an argument of where we're going. That is we're trying to move away from relying entirely on selling widgets. We want to keep selling widgets, but we don't want it to be where we're having to sell more and more widgets and compromising patient care and our own health. So this is Bitcoin Man. Bitcoin Man is a tragic figure, and I think he's a common figure in medicine. He's a 44-year-old surgeon from Massachusetts. This was in the Wall Street Journal. He's 44 years old. He has 3 kids. He's got savings of, I think they said $125,000. And so Bitcoin Man is busy being a surgeon, but he figures, oh, I can do this. I can do surgery, so I can take care of my finances. He put it all in Luna coin. And all you guys back there know that Luna coin has completely crashed. You know, they delinked the stable coin, and he literally lost his entire life savings with 3 kids at home, and he's 44 years old. So this is the opposite of what I would suggest people should do. So the first thing you've got to do is just make a business plan. And I would encourage everybody to have a business plan, a personal business plan. And it's really easy. You know, you can make it as complicated as you want, but it's really easy. You just look at your long-term financial obligations and then your long-term income goals. We talked about retirement, and again, I'm not a financial advisor. That's not what I do. But most of the models for financial advisors are to replace 50-60% of your income at retirement. So you need to understand what that number would be projecting out into the future. You have to build a team. While you're operating, taking care of people, you can't be taking care of your day-to-days. And I write on there, pay up, because unlike in medicine, where every neurosurgeon gets paid the same, whether they're good or bad, it is a huge difference in the accounting and legal world. Pay extra to get that extraordinary accountant. And by example, your accountant can serve as a sounding board. I suspect Bitcoin Man would have been told not to make his investment in Luna coins if he had run it by his accountant. Lawyers are critical. I've got about 10 lawyers that are, Alan smiles, yes, I'm covered up in lawyers, but they're critical. They're the ones who can make your life, while you're operating, doing other things, they can take care of many of the transactional things. They can worry about your estate planning. and to what degree you might need asset protection. So I'm working toward this plan of you all being able to operate and these things taking care of themselves. The first thing is to commit and deploy your capital. So after you have your business plan, you've got this excess capital, which is great. I've showed you, you've got it. I like the idea of mortgage. The reason I put that up is that I had to contemplate why it is that most people's primary residence is their largest asset. Because it certainly isn't in my life, and it doesn't make sense to me, but it does make sense when you think about it. You have a legal obligation to invest every month. So it's forced investing. And I think there's a big message to that, that's how you end up growing this asset. So you need to make that commitment to yourself where you're going to essentially establish a mortgage for yourself. I would argue you do it every month. Go early for sure. Compounding is something that people talk about all the time. Einstein called it the greatest force in nature or in the universe. But I like to think of compounding in a simpler term. I like to think of it in doubles, so that the S&P 500 returns in nominal terms about 10% a year. That's a 7-year doubling time in nominal terms. So if you think about doubles and you're 30 years old, you might want to have 7 doubles, or call it 5 doubles in your lifetime. So just, you actually have to hear the numbers to just understand what compounding does. So 100 becomes 200,000, 200,000 becomes 400,000, 800,000, 1.6 million, and $3.2 million. That's compounding. And you start with $1 million, with 100,000, you end up with $3.2 million. You just cannot possibly understate the important or overstate the importance of compounding, and go big. So go big and go early. Why go big? I told you that you want to replace some percentage of your post-retirement income, and call it 60,000, make 60%, whatever number it is, and everybody has to come up with their own number. The important point is, and it's a horrible number to know, $1 million is worth $35,000. So you sit there and you go, well, $1 million, if I had $1 million, well, $1 million is $35,000 in recurring income. So that's the number you should just put away in your head. And then you understand why I say go big. So if you want to replace, you need $100,000 of replacement income, you need $3 million. And so on and so forth, all the way up to whatever your number might be. And maybe your number's 35,000, but maybe your number's 350,000. Whatever your number is, if you think about $1 million as 35,000, you'll understand why I say go big. And then you have to deploy this excess working capital. So first you have to commit to it, and then you have to deploy it. The buckets, kids' education, healthcare, and retirement. These are those long-term obligations and liabilities that you have on your balance sheet or on your financial plan looking forward. And again, I'm not a financial advisor, and I'm not trying to play that role. What I am trying to do is tell you that these are predictable things in your lifetimes. Education's first, because most of well, for one thing, it's predictable. You have a kid 18 years later, they generally have education expenses. The other thing is usually that's early in your career, so it's the hardest one to commit to. But the great thing is these 529 plans, and this is one of the few gifts from the government. You put the money in, it compounds, grows tax-free, comes out tax-free. It's transferable, so if your kid doesn't use it, you can pass it on. And as of 3 or 4 years ago, it's been where you can actually pay for your kids' private schools as well at some limit. So that's education, and it's easy. So just all I'm telling you about education is 529 plan. I'm trying to make it simple so that you guys can get back to clinic. Healthcare is one of these things that you don't know about. It's one of those long-term liabilities that kind of hit you in the face. Everyone knows about their insurance, their daily health insurance, but there's a $325,000 estimated cost to a couple today retiring for healthcare costs, and that's with Medicare. So that's taking your personal contributions to Medicare It's taking all the other things, your glasses and your dental, $325,000. So the day you retire, you're going to have a $325,000 liability. Another great gift from the government, the health savings accounts. And the nice things about those is you get a trifecta out of it. They're deductible going in, they grow tax-free, and they come out tax-free for appropriate healthcare expenses. And for many people in academics or employed positions, they don't have health savings accounts. There is this little known fact that you can convert your IRA to an HSA. And what that allows you to do is pay your healthcare expenses with pre-tax dollars rather than with post-tax dollars. Disability insurance, I don't know anything about disability insurance. I will tell you that they try and scare the bejesus out of you that you're 10 times more likely to be disabled than die. But the reality is probably none of you will be disabled and none of you will die. The only thing I will say about it is that if you do look into disability insurance, there's I wouldn't call it a scam, but they have better lawyers than most people. And just make sure you have a lawyer review the same occupation clauses. Life insurance, I never had life insurance. I don't find a need for life insurance, but if you do have life insurance, don't get whole life insurance, in my opinion. Indeed, the more complicated something is, the more likely you are to lose money. And whole life insurance is very complicated. Term life is simple. But here's the thing that I think I can bring to the table just through my 50 years now of finance. And that is how do you make a plan that you don't even have to think about? And as I've opened up a fund to public money, which again I've been doing for a few years, I've realized that doctors are these unique people who come and want to invest with me. And honestly, I try desperately not to have them invest with me. They're just so challenging to interact with. And I've had to think about why that might be. And I think for one thing, because I think I'll say it in this room, it's not a lack of intelligence, right? I mean, I'm dealing with extraordinarily intelligent people. So that's not the problem, but they're overly confident. And I would say Bitcoin Man probably would have been better off maybe getting someone else's opinion on his Luna investment before he did it. Overly competitive. Business by its nature is not a zero-sum game, it's collaborative. And I think that competitive drive is harmful to your long-term financial plan if you allow it to be. But I think the biggest thing is capital allocation, because most doctors, again, think of themselves as selling widgets. I operate, I get paid. Business people think of it quite differently. It's capital allocation. I put forth a capital outlay and I expect a return on investment at some point in the future. And business people are very comfortable with that, and doctors are not. And I think that's ultimately harmful to doctors. And of course, there's no time for a second career. You can't be doing what I do if you're practicing neurosurgery. So I spend about 60 to 80 hours a week managing assets. So this is now getting to the big nut, which is that thing that you want to accumulate while you're operating. So the easy pickings is any tax deferred, tax favored thing you can put your money into, do it. Whether that be a 401k, a SEP, a KEO, whatever it is, just do that. The second thing is don't lose money. And it's really hard as a money manager. If my portfolio goes down 50%, I got to return 100% to break even. And these are devastating numbers really to recover from. And Bitcoin Man is in a world of hurt. It will be very challenging for Bitcoin Man to recover from this. And these are those so-called dumb doctor deals that we all hear about. And I put VCPE. My CEO said, but Richard, you do all these things. And it is true, I do all these things. But I would say that you've got no business investing in private equity deals, venture capital deals, or real estate for that matter, until or unless you've covered your buckets and you have enough time to commit to get educated about these things in a way that you won't be taken advantage of. Because as doctors, you get taken advantage of because you're too busy. For instance, I'll take private equity here. In private equity right now, there's a big thing where you get, as a doctor, you get told the IRR, the internal rate of return, and usually they'll tell you it's 20, 22%. What they won't tell you is that they've created what's called a credit facility, and they're baking the numbers. So your IRR is probably going to be closer to 8% on that number when you factor in the credit facility. You don't need to know what I just said. You just have to realize you don't know what I just said, and therefore you shouldn't be going into private equity. And of course, get rid of debt, because that's that constant drain on you. If you have low interest loans for your student debt, you might keep that, but definitely be sure that you're maximizing your IRAs, your 401ks. So here's how you do it. You keep it so ridiculously simple. So I've written down stock picking is bad and index is good. And again, this is just my opinion speaking. So stock picking is bad, index is good. So the index is the S&P 500. And there are now ETFs that you can buy, exchange traded funds you can buy that replicate the S&P 500. I put VU up there as an example. VU is the Vanguard product. It charges you 3 basis points, which is 0.03% of management fees. If you turn your money over to a financial advisor, they'll charge you 2%. You can buy the index for 3 basis points. If you turn your money over to me, it's 2% and 20%. So I'm extraordinarily expensive. You can just buy the index, and I'll give you an extraordinarily strong argument on why that's the right thing to do. Mutual funds are bad. Mutual funds generally charge 2%. They always underperform. It's virtually impossible when you're knocking 2% off and running a mutual fund. It's virtually impossible to outperform the index. And bonds are really bad. So as you go through life, you'll be told these things. And again, this is my opinion, 60-40 in bonds and your age in bonds. These are what the financial people will tell you. The bonds are horrible. They pay an interest rate that doesn't change with inflation. So that coupon stays stagnant for whatever the life of the bond is, unless they're tips. That income is ordinary income. So it's tax disfavored. And the underlying asset, the bond, can fluctuate price, but at the end, it's only worth what you put into it. You take a public equity. Public equity pays a dividend. That dividend almost always keeps up with inflation. It's tax favored, and the underlying asset grows. Typically, we said at 10% a year. So $100,000 in a bond pays you $3,000 a year. $100,000 in private equities pays you $12,000 a year. That's the 2% yield plus the 10% on the capital appreciation. So personally, I don't think anyone should ever own a bond. We trade bonds, but we don't own bonds. So avoid. So I'm making an argument that you should simply buy the index and never watch a financial TV show and never read a financial newspaper. You will lose money. I assure you, you will lose money doing those things. So I love this. This is Jim Cramer says, get as many DD shares as you can. This was at the IPO. And to those who don't know, 7 days later, it was down 70% and they are now delisted. But this is the great information you get from TV shows. And indeed, this is why I created the algorithm 25 years ago, was because I realized that these people have no idea what they're talking about. So this is from a quote from Benjamin Graham talking about the difference between investment and speculation. And I just emphasize the part where he says upon thorough analysis. So if you're buying a stock because someone told you to buy it in the surgeon's lounge, you'll probably lose money. So thorough analysis means, do you know what their operating margins are? Do you know how their margins are growing? Do you know what their revenue are? Do you know what product they sell? Do you know what their currency risks are? Do you know what their credit risks are? And when you know those things, then you're investing. Otherwise, you're speculating. So this is if you're going to go off and do that, if you're going to speculate on your own and go pick stocks, the one thing I would encourage you very strongly to do is to to keep a report card. And a report card doesn't mean on any one asset. It means on all your assets. At 12:01 every day, I get a report card. Every day I get a report card at 12:01. And it is extraordinarily humbling to get that report card. This is one of my investors in Houston. He called me one day and he said, "Hey, Richard, man, my oil and gas is killing it." This was maybe February of this year. I said, "That's great, Steve. What you got?" He told me ExxonMobil. So I pulled up a graph, a six-month graph of it. And I said, "Wow, you're doing great, Steve." I said, but let me just, I'm going to send you a graph. And I don't want you to call me back. I just want you to look at it. And I'm telling you, he thinks he's knocking out of the ballpark. So I sent him this graph. So this is a graph of the index SPY versus ExxonMobil over 10 years. So he's all happy because he's at this bottom part of the curve here. And my mouse isn't quite, but you can see the bottom, the ExxonMobil, where it's making this updraft. But what he should be focused on is he's up 14% and he should be up 205%. And this is the bias that we all have as we look at our performances. And so I would encourage you, if you're going to go off and pick stocks, be sure you're keeping an honest report card. The number I can tell you, the industry-wide academic number is 2.9%. If you manage your own portfolio, you'll return 2.9%. That will be your number overall when you account for the fact that you'll be uninvested, underinvested in your choices. So you're giving up 10% to get 2.9%. Again, don't open these financial magazines and try and do it on your own. You'll just lose money. It makes no sense. Which you'll never hear from any other financial person other than me for the rest of your careers. Okay, don't try and time the market. So this gets back to picking stocks and timing the market. These are all the things that what we call retail investors, or the derogatory term is dumb money. Trust me, there are a lot of institutional guys who are dumb money too. But this is what happens timing the market. So if you look, the red line is the graph to CPI, so that's inflation. And there are all these events listed on there: recession, oil crisis, savings and loans. And as you see, no matter what happens, all those things that seem like the world was coming to an end since 1957, the market has done nothing but gone from bottom left to top right. So there's no reason to try and time the market. Just stay put. It's absolutely the right thing to do. And it gets worse trying to time the market. And these are just stunning facts. So this is, if you look on this, if you look down here, price return, this is since 1930. If you follow it all the way down, well, if you follow it all the way down to that column, you see at the bottom, it's 17,000%. So if you go over 2 columns over, you say, if you miss the top 10 days in every decade, which is what you'll miss if you try and time the market, because the market crashes and usually those big up days are quickly following the down days. So you will miss those days. You get 28% versus 17,000%. If you're in, you know, we talk about greed versus fear. So if you're the greedy person, and you look at that 3,000,000% return there, but that's knowing how to miss the 10 worst days every decade. So timing the market's bad, picking stocks is bad. It's just frozen. Oh, there we go. So what's worse than trying to time the market is represented here. So this is over 20 years. The first thing you see here, this is perfect timing. You were given money every year and you invested it at the absolute low. You have $151,000. If you're bad at it, that is, you deployed it at the exact high of the market, you still do pretty good. You got $121,000. If you stay in cash the whole time, you got $44,000. So this gets back to remember the plan. You commit the capital, you deploy the capital. So you commit the capital so it doesn't stay sitting there in cash, and you deploy it without picking stocks and without trying to time the market, your best outcome would be if you just went and operated. And particularly since the best unit of time for you all spent, your return on unit of time is absolutely being a neurosurgeon. Anytime you spend trying to pick a stock, you're damaging your wealth. So there's the summary. So go early, go big. I think I made an argument for that. Buy the index. I think I made an argument for that. That 10% nominal return in the S&P is dependent on reinvesting dividends, which is called a DRIP program. Be sure and do that. That dollar cost averages you in. And don't open the envelope. And what I mean by don't open the envelope is especially like right now, you know, we just had our worst half since 1970. There are going to be a lot of people open their 401ks and freaking out. Just don't open it. Dr. Green raised his hand. It's terrifying to look at. Don't open it because you'll make bad choices if you do that. Instead of opening the envelope, just go to the operating room. So there's this quote from Warren Buffett that if you don't find a way to make money while you sleep, you'll work until you die. I think for neurosurgeons, I see that differently. My quote would be, if you don't find a way to make money while you sleep, you'll be in clinic till you die, which is probably worse. So I hope I made an argument that taking care of your finances will allow you to just go over there and do the thing that's the most beautiful thing on earth, which is helping other people. And I think that if you commit to that simple plan, it improves your physical, mental health, your family life, and your ability to provide the best possible patient care. Selling more and more and more widgets is great if that's the thing you want to do. It's really horrible if you're doing it because you have to. So that's it. I appreciate being able to be here. I hope you guys get something out of it.
Richard, that's a fantastic talk. That's a question. I was hoping you were going to hit on as a resident, you know, because the resident and how, you know, that kind of started. I think it started before residency, but what you were doing as a resident to get to where you are today.
Well, that's a good question. And I will tell you that this really is a reflection back on that. Like, how would I tell me to do this 30 years ago? I will tell you that I was raised by a businessman. I literally was a disappointment to my father that I went into medicine. I had an econ degree. I was supposed to do medicine. My wife and I have been married 30.
Supposed to do business.
I was supposed to do business.
Right.
My wife and I have been married 33 years. She'll tell you there's not a moment that I have not been in the financial markets or doing these things. So this is something that I've been doing really since 1974. So it's a little. Again, I'm not sure I'd argue anyone should do things the way I did it because it's taken such a big part of my life to do it. But what I will say is that what I did do is, and continue to do, is I live on a tiny fraction of my income. And the residents, I know you guys are not making huge amounts of money, but you're actually making really good money. If you go out into the market, you know, family of four is making $52,000 a year. Family income, $52,000 a year. You're making good money. And so the argument that you're underpaid and you can't do it, I would say is flawed. I think you just make a commitment. And that commitment is whatever you want that commitment to be. And you have to make that decision. I always wanted to have more capital to work with. So I always lived way, way, way below my means and continue to do so today. But I think it's go early and go big, Alan. I think that, and as a resident, certainly that's what I did.
So you're putting in 110 hours of clinical work a week as a resident, and you probably were even doing more back then. Where is there any time to do anything except sleep?
Yeah, well, and that's a really good point. And I'm not sure during that period of time, because it was 120 hours a week. I'm not sure. I mean, I know I had the assets. I know I controlled them, but I didn't, it took getting out of residency really for me to grow into the true financial. So I launched Westmark Enterprises probably the year I graduated, or maybe the year after that.
Graduated residency.
Graduated residency, yeah. And it took, it takes capital in order to do those things. But that, again, I would say that's a path that if anybody really wants to do it, I'd love to talk to you about it, but it's a different path. It's not most doctors' life plan. And again, I feel so happy for you all that you will get to do what you get to do. It's just amazing to get to take care of other people and help them. But Alan, it's a full-time commitment, and that's part of the point here is that you can't go out and part-time your wealth management. You just can't do it. You'll lose money.
So, Richard, excuse me, I don't know if I'm talking too loud, but this is a different day. And when I grew up, I started several companies, and I was convinced that was sinful as an academic doctor, and I gave them away literally. But today, I think these guys have an opportunity that maybe we didn't. And that is the digital market, the technology market, and using very little time, but using their intellectual capabilities, I think they can create, ideas and develop them with business people and have opportunities that maybe weren't so readily available in my generation and, are more so now. And I think that there's all these startups and they have opportunities to consult, they have opportunities to get patents. And this is something very legitimate. It's not a sin, as I was told. It's okay to make money. So I think that's something that you should maybe comment on, because there's a lot of capacity behind me, and I think opportunity exists.
Well, I think those are all great points. I think the fact that it's not a sin is one of the things that I think you can't think like that. It's harmful to you to think like that. And Dr. Green has talked about the fact that's the way it's always been in medicine. If you talk about money or think about money, you're unethical or dirty. In terms of the startups, I don't know about that. When you're inside the industry, you realize just how hard it is to get a fair shake. I mean, it's just really, really hard. A friend just pitched me as a thing for, it doesn't matter what it is, but it's second opinion insurance in emerging markets. He gave me the numbers: 1.5 times EBITDA with a 4.75 earnout. EBITDA earnout, 500,000 promote, 250,000 a year in management. So to a doctor, they would look at those numbers and honestly, they wouldn't even know what they meant. In fairness, they just wouldn't know. I look at those numbers and I understand that there's absolutely 0% chance that they'll ever hit their earnout numbers. It won't happen. So if you're going to pursue those things, just understand that unless you're the founder and unless you're the one leading the charge, you're likely to be taken advantage of and in really serious ways. So I think you're right, but I also think it's a treacherous and dangerous path to go down.
We talked really briefly with coming up here about some of the boards that you're on, some of the philanthropic work that you do. And I think that's something that can't be missed on all of this. And I think in general, and especially when I look at our faculty, I think there's some of the most generous people that are out there, when we're looking to create something. And we're very much on a startup. And in fact, for our current scholarship, I mean, at the beginning, almost all the money was coming in through neurosurgeons. And so you can also look at this as a mechanism to exert by being financially successful. It's a mechanism to be able to exert good things that you will have options to make a difference in healthcare and research, et cetera. So it's not just like I want to make money, but I want to be successful so that I can, give back, sort of.
No, I think that's a fantastic point. And Kay and I are to a point where that's what we're doing. Our foundation is now, we're giving away money. And so I mean, I love the idea that the doctors are contributing to it, and it fits the whole narrative that, doctors tend to be people who like to help other people. And so gathering enough assets, you can't give away assets till you have them. And so by thinking about money, then you can have these assets, and whatever your mission statement is. And I made a comment about that because I don't know what some of you people might want to go out to Silicon Valley and do a startup. Some of you might want to give up all of the United States, move to Africa. I mean, whatever it is, it will require money, whatever it is. And you have this unique opportunity to be able to secure your future pretty quickly and pretty easily. But you have to work at it.
Silicon Valley, by the way, is called money.
Yes.
Do we have any questions from our Zoom listeners? Please unmute and shoot away.
Dr. Westmark, thank you so much for that talk. I think part of being a resident, we do, right? We have a good income and we have like some level of financial stability as of now. But oftentimes the amount of money that we do have in order to invest these things, oftentimes we kind of keep close, meaning, there's a philosopher who once said scared money doesn't make money. And I was curious about how you go ahead and kind of evaluate. For example, the way that I look at it is if I know about it, I feel like I'm more able to invest my time, invest my money and that kind of sort. So how do you just kind of globally look at, say, like a new investment or a new opportunity, whether it be a fund, whether it be any sort of asset that you're interested in putting your capital into? What is your kind of overarching kind of framework for how you evaluate the risk for something like that and how you evaluate what the return could be about something like that?
All right, well, that's a good question. It's how I spend my day. I think getting back though to Dr. Levy's point and your comment about having a limited amount of capital, I would say that the one thing you absolutely should make sure you're doing is maximize whatever the university is giving you in terms of retirement plans. Whatever it is, just do that and not even question it. The best thing I do when I look at opportunities, the single best skill I have acquired through the years through really bad outcomes is I've gathered the ability to say no. And saying no is the best thing you can almost ever do, because so many of these deals, I mean, when you get into the private equity deals, the VC deals all sound exactly alike. If you know what total addressable market is, TAM, somehow every private equity company, VC, somehow has a TAM of 10 billion people, which is challenging given how many people live on the planet, right? And they're all going to cure cancer. And they're all, they're going to exit at 7 times EBITDA and, 3.2 years. They're all the same. And this is the vulnerability. This is why I would argue that you really shouldn't ever do these things, because you need deal flow and you need people, analysts, people you hire who can work for you to do those evaluations for you. It's very dangerous to do those things. So I moved almost completely away from the private markets into the public markets. The public markets had the benefit of the SEC. There's a law called Sarbanes-Oxley where you literally go to jail for misrepresenting facts in a publicly traded company. It doesn't exist in the private world. That guy who's got a device that they're telling you is going to be great and save the world, there's no penalty for him telling you whatever that he or she tells you. So I guess my biggest answer is just say no, but I have infrastructure that allows me to look at things differently. But I am so tired of that inconsistency in the private world that I'm moving almost entirely into the public markets. Then when you start talking about looking at public equities, it's really the same as looking at private equities. It's just, it's more transparent. But every single public company has to report any material event that they experience. And I read every one of those. It's extraordinarily laborious. So I read every one of their quarterly numbers, every one of their annual numbers, and any of the so-called 8 filings that come out. It's extraordinarily labor intense. And so it gets back to why I said my best advice is don't try, because it's really hard to beat the index. It's really hard to beat the index. Even as someone who spends my whole time doing it and gets paid to do it, it's really hard. And I'll get back to the point that for your unit of time, neurosurgeons get paid so much money for your unit of time that I would argue it's a bad allocation of resources. But if you want to know how, I'd be pleased to talk to you individually about it. Thank you very much for having me. Thank you. Thank you very much. It's an honor.
That was a phenomenal talk, Dr. Westmark. Very hard act to follow, but I'll try to make my presentation short and sweet for you guys. For those who don't know me, I'm Roberto, one of the residents here, and today I'll be giving a brief talk about rheumatoid arthritis for the spine surgeon. Here's the outline for today. I'll talk about why it's important for us as spine surgeons to know about rheumatoid arthritis. We'll talk very briefly about the pathophysiology behind RA and mention one of the some of the most common spine pathologies seen in cervical spine. And then we'll follow talking very briefly about the surgical management of this spine pathologies. Then touch base about the pharmacologic treatment in RA and its impact it's had on our field in spine surgery. And lastly, we'll talk about the perioperative management of RA patients. So why RA? So RA patients, they have unique physical and radiologic findings, and usually they have a systemic inflammatory arthropathy that makes examining these patients very challenging. And if we're not careful enough, we can miss subtle myelopathic findings. Secondly, also they have unique spine pathologies, especially in the cervical spine, which are often multiple. And when they require treatment, surgeries are usually challenging. Thirdly, when you see these patients in clinic, they usually come with a long list of medications, and we as physicians should be able to, understand and manage these medications in the perioperative, time. On top of that, they have complex medical history, and they have increased risk of perioperative complications, especially because they have increased risk of cardiovascular and pulmonary disease. And lastly, and most importantly, is that their recovery is very different from a usual spine patient, because again, as they have systemic inflammatory arthropathy, they have problems postoperatively working with physical therapy and occupational therapy. And we have to keep that in mind, especially when we're managing their medications. RA is characterized by infiltration of the synovial membrane and the joints by inflammatory cells, especially T cells, B cells, and monocytes. They have expansion of the synovial layer with fibroblasts and macrophage-like cells that lead to a hyperplastic synovial lining layer. This pannus, as we know, invades the joints and can lead to bony erosion and cartilage degradation. Pro-inflammatory cytokines, especially TNF and interleukin-6, mediate the signs of and symptoms of disease, which is usually pain, swelling, and degradation of cartilage. Stimulation by these cytokines can generate osteoclasts, which usually promote bony damage. Interesting, there are some post-translational protein modifications in RA that can lead to autoantibodies against autoantigens. And these autoantibodies can form complexes that can activate the complex cascade and lead to inflammatory responses in joints. Interesting, the length of time before the appearance of RA symptoms is related to a specific antibody profile. Here is a figure trying to summarize the pathophysiology behind RA. I don't know if this is working, probably not. Here. So here we have on the top left, a autoantigen that is being presented by an antigen presenting cell to a naive T cell. The naive T cell becomes activated and in fact can activate macrophages and activate B cells to differentiate into plasma cells, which in turn can secrete autoantibodies and bind to their respective autoantigen and form immune complexes. These immune complexes can deposit in the synovial joints and cause an inflammatory cascade, and also in turn can activate macrophages, we can see here in the middle, which can induce pro-inflammatory cytokines that can activate osteoclasts and chondrocytes and lead to bony degradation and cartilage degradation. Women are affected 2 to 3 times more than men. The peak incidence is usually around the 6th decade of life, and there is both genetic and environmental risk factors, and it's associated with HLA class 2 antigens, especially the DRB. And environmental risk factors are known as smoking, periodontitis, the microbiome of the lungs, GI tract, and mouth, as well as some viral infections. Interesting, there's some species like the Prevotella that are found in the GI tract in patients with RA and are believed to have a role in the pathogenesis. New data also suggests that bacteria may translocate from the GI system into the joints and cause the inflammatory cascade. As we know from medical school, classic RA manifestation in the joints include joint space narrowing, bone erosion, subluxation, and ankylosis. But how about the RA manifestations in the spine? So cervical spine is believed to be involved in between 40 to 88% of patients with RA, and it's the second most commonly involved region of the body. Interesting, 42% of the patients have both lumbar and cervical involvement in patients with RA. Again, facet joints are synovial joints, so they undergo the same destruction of the synovium and cartilage. This progressive joint damage leads to a ligamental laxity, which can result in subluxation and instability of the spine. The combination of all these changes mentioned can lead to spinal deformity that can be seen in around 28% of the patients. What are the most common RA spine manifestation? And there are ventral, vertical, and subaxial subluxation. Ventral subluxation or atlantoaxial instability makes up around 65% of the pathology seen on RA on the cervical spine. And they're due to the unique anatomy of the OC1 and C1, C2 joint. First of all, they don't have a intervertebral disc to support them anteriorly, as different with a subaxial spine. Also, secondly, the orientation of the joint is mostly horizontal, and they do not have a bony barrier. So the only thing that's holding this joint together, it's mostly the ligaments, especially the transverse ligaments, as we know, and they're usually involved in RA and they're destroyed, which leads to instability. There are multiple radiologic measurements that you can use to diagnose atlantoaxial instability. One of the classic ones is the anterior atlantodental interval. It's less than 3 millimeters in adult patients and less than 5 in the pediatric population. But there are many others that we can use, especially the posterior ADI. And this landmark paper by Bowden back in the early 1990s, he described how the posterior ADI has the highest sensitivity of diagnosing and predicting neurological deficits in patients with RA with a sensitivity close to 97, which is much higher than anterior ADI. And here on the right, you can see how you can measure the posterior ADI. Here's just an example of one of our patients with atlantoaxial instability, and you can see abnormal movement of flexion X-rays on the left. Next, we have vertical subluxation, and this is basically just ascension of the odontoid process into the cranial fossa. It's due to erosion of the OC1, C1, C2 joint and loss of substance of the lateral masses. It makes up about 20% of the cervical pathologies in RA, and it's the second most common one seen. Again, there are multiple ways you can diagnose this in X-rays and CTs, but I'm just going to mention a few of them. We have the Rna C12 index, which basically measures the distance between the C2 pedicle and a horizontal line between the C1 arch. And usually more than 15 millimeters is considered normal. Anything less is abnormal. Also, we can mention the McRae line, which goes from Bayesian to the posterior lip of the foramen magnum, and the Chamberlain line that goes from the hard palate all the way to the posterior lip of the foramen magnum. And lastly, we have subaxial subluxation that results from destruction of the facet joints and uncovertible joints. Interesting, the lack of ossified formation in patients with RA results in relative instability as opposed to patients that have arthritis that develop a rigid cervical spine due to ossified formation. This makes up about 15% of the cervical pathologies seen on RA. Again, this is just an example of one of our patients with C4, C5 subaxial subluxation. So how do we evaluate patients with RA? Again, I mentioned it's very difficult because of their arthropathy to examine them. So there are some classification grading systems that we can use to try to help us communicate how the patients are doing neurologically. So the Rna classification scale goes from class 1 to class 3B. Class 1 is usually patients that are neurologically intact. Class 2 is patients that have some kind of subtle weakness with early signs of myelopathy. Class 3A, usually patients have long tract signs, but are still ambulating. And class 3B is patients that have severe myelopathy and are unable to walk. Some other neurological findings that you can see in patients with RA includes back meningitis, vasculitis, peripheral neuropathy. And also these patients are prone to fractures due to decreased bone mineral density. And we'll talk about that in a little bit later. So what are some of the operative indications for RA? Some clear-cut ones are the presence of myelopathy and neurological deficits. Intractable pain is also another indication for surgery. But there's still some controversy in patients that have markedly abnormal radiographs, but in the absence of symptoms. Depending on what you read, some people recommend to have close follow-up with those patients. And if there's any radiological evidence of disease progression, then to intervene in those patients. Before talk. No, not really. I mean, I can mention some of the few ones I've saw. One of them is the posterior allantodental interval. They recommend if it's less than 14, I think that's the threshold to proceed with surgery, even if patients are asymptomatic, especially because most of the patients with C1, C2 instability, more than 50% of the patients, if you follow them for 5 years with no surgery, they usually progress in their disease. So. Yeah. Perfect. Thank you, Dr. Levy. Before talking about the present surgical treatment of RA, we have to talk about the evolution of treatment of C1-2 instability, which basically help establish the treatment for patients for RA. Just to mention a few of them, there are a lot, but on the top left, you can see the Galley fusion technique, which was the first sublaminar wire, I think was described in 1939. On the bottom left, we have the Brook-Jensen sublaminar technique, which usually they use to separate iliac crest allografts wrapped in a sublaminar wire. This was described around the 1970s. On the top right, we have obviously the 1990s, the Sontag cable technique, sublaminar technique described. And on the bottom right, we have the Halifax clamp. Thank you, Dr. Levy, which was obviously developed to treat C1-2 instability. Again, surgical treatment for ventral subluxation is usually C1-2 fusion. There's different techniques. I'm going to mention a few of them. We have transarticular screws that were described by Magriel, C1 lateral mass screws with C2 part screws described by Gall and Harms, or using C2 pedicle screws, which was also described by Gall and Lahiri in 1994. Important, if the patient has isolated ventral subluxation, the oxybutyl should not be included or in the construct, because obviously there's going to be lower fusion rates, increase the morbidity of the procedure. Here is just to talk very briefly about the different screws that we can use, especially in C2. We have on the right, the purple one, which is a transarticular screw, which has a steep angle going to the C1-2 joint. The yellow screw is the laminar screw that we can use as a belt-out technique. The blue one is a C2 pars screw, which basically follows the pars, and the C2 pedicle screw, which has a higher entry point and a more medial trajectory. That's one of the other options. Obviously, whenever you're trying to achieve one of these techniques, you have to study the preoperative CT or imaging that you have to make sure that there's no apparent vertebral artery. Here's just an example of one of our patients that had C1-2 instability and was treated with a C1-2 fusion. Next, we have vertical subluxation. Usually these patients require occipital cervical fusion. And depending if the patient has anterior neurological compression and that the vertical subluxation that is not irreducible with traction, some people argue to do anterior and posterior decompression with the posterior fusion, although most people have stepped away from doing anterior approaches due to high complication rates. And lastly, subaxial subluxation. This is case by case, depends on the level. You can do an anterior or posterior approach to treat these patients. Neurological outcomes. Majority of the papers are kind of from the early 2000s. There's some conflicting evidence, but the majority says that the severity of the preoperative neurological deficits are an accurate predictor of postoperative neurological status. Most patients have improvement of their preoperative pain after surgery. And what is clear is that patients that are non-ambulatory or class 3B Rheumatoid have doubling of complications when compared to any other patients, especially the patients that are able to walk. So this argue that patients that are severe malopathic and not able to walk, you want to intervene as quick as possible on them, or maybe wait and don't wait until they're non-ambulatory. In the early 2000s, there was a rise in papers talking about the surgical trends of RA patients. This is one of the landmark papers that talk about the changes in rates in joint surgery in patients with RA in California during a 25-year period. And you can see here on the right, the most joint surgeries decreased significantly in the early 2000s. Especially in patients that were between 50 to 60 years and have an RA diagnosis. And how about in the spine? Stain and Company also published a paper looking at the trends in cervical spine fusion in patients with RA. And we can see here on the left that the incidence of allantoaxial fusions performed during the early 2000s increased in the general population, but decreased in patients that had an RA diagnosis. On the right, we can see that the incidence of posterior cervical fusions increased both in the general population and in the RA patients, but the increase in the incidence in the patients with RA was significantly less. And this coincides with the implementation of disease-modifying antirheumatic drugs. They usually aim to suppress inflammation caused by overreactive immune responses in these patients. There's two types of DMARDs: synthetic, which are small chemical molecules that are given orally, and the biologic DMARDs, which are usually bigger proteins that are administered parenterally. Here's a table showing the currently approved DMARDs in the United States. And of note, the biologic DMARDs are usually target TNF-alpha. So we aim to have an updated view of what are the recent trends in cervical spine surgery across the state. And we wanted to validate this and look also at our numbers. We look at Dr. Levy's series of cervical fusions, and the overall number over the years of all patients with cervical fusion increased, but patients with RA, the number of RA-related cervical fusions decreased significantly. When we look at the procedures, different procedures, the C1-2 was the one that decreased most significantly. And in patients who were on the DMARD treatment, also C1, C2 fusion was had the biggest decrease over the years. When we compare our numbers with the national numbers, the number of OC fusions, posterior cervical and anterior cervical fusions in the general population on the RA patients have increased over the years, but the procedures related to RA patients was significantly less than in the general population. So basically our updated numbers correlate with what has been reported before. Now that we know that RA-related fusions have been impacted in some way by DMARDs, especially in the reduction of the total numbers compared to the general population, we want to know what's the role of the biologics or DMARDs on having their effect on C1, 2, or vertical subluxation. Is it that they basically inhibit the de novo formation of cervical lesions, or is that they can basically reverse the damage that has been done by RA? And this group from Japan published their series of patients being treated with biological agents. This was published in the Spine Journal. They basically look at around 56 patients that have a disease duration around 10 years and a follow-up of 4 years. They were at least treated 2 years continuously with biologics, DMARDs, and they look at their series. And basically, of 12 patients that had no cervical spine lesions, only one of them developed a new de novo lesion of the cervical spine. In the contrary, patients that had allantoaxial instability, 15 of them that were looked at 12 had disease progression after final follow-up. And also they look at vertical subluxation and 11 of the patients that were seen initially, 9 of them had disease progression. So basically after a multivariate analysis, they concluded that having a pre-existing cervical spine lesion was a risk factor for progression of cervical spine lesion. Again, the same group, a couple of years later, published a similar paper, but looking now at close to 100 patients. Again, they had at least 10 years of disease of RA, and they had a final follow-up of 4 years. Of the 44 patients that did not have any lesions at baselines, only 3 of them developed a cervical spine lesion at final follow-up. And again, in patients that had atlantoaxial instability and vertical subluxation, around more than 75% of them developed a progression of their disease. So again, after a multivariate analysis, they saw that the biggest risk factor for progression of cervical spine lesion was a pre-existing cervical lesion. So what can we conclude for both of these studies is that if you already have an RA-related cervical instability, biologics basically cannot stop the progression of the disease. But if you don't have a cervical spine lesion from RA initially, biologic treatment can prevent you from developing one. Lastly, now that we know the recent trends, thanks to DMARS, we're going to talk about the preoperative management of these patients. Again, due to their chronic inflammatory environment, they have increased risk of cardiovascular events, thromboembolic events, infection, and osteoporosis. On top of that, the drugs that are used for treatment for RA, they all have their pharmacokinetic properties and risk profile. For example, methotrexate treatment should not be stopped during surgery, should not be discontinued during surgery because it has a low risk profile. But on the other hand, Tnf-Off inhibitors have a 10-time increased risk of postoperative infection if the last dose is given one administration interval before surgery. So here is just a scheme showing the preoperative management of Tnf-Off inhibitors. For etanercept, it's usually recommended to stop 1 week preoperatively, and infliximab and adalimumab to stop 4 weeks before surgery. If the patient has any signs of infection postoperatively, the Tnf-Off inhibitor should not be started until 1 week after the last sign of infection. And if there's flare-up of the patient symptoms of RA, but no signs of infection, the therapy should be started immediately. And this is to help the patients mobilize after surgery. And lastly, if the patient has proper healing and no signs of infection, it is recommended that this medication is started between 1 to 2 weeks postoperatively. Interesting, patients with RA have a high prevalence of osteoporosis between 30 to 50%. And this is due to the inflammatory cytokines that have a negative effect on osteoblasts and a positive effect on osteoclasts and bone reabsorption. On top of that, some DMARS and corticosteroids are known to inhibit new bone formation. So the fusion rates that have been reported for RA range in between 15 to 90%. So it's important for us to screen patients for osteopenia and osteoporosis before we proceed with surgical intervention. This links to one of our other papers, which we look at the osteoporosis treatment in patients undergoing spinal fusion. And basically, we saw that teriparatide, which is an anabolic medication to treat osteoporosis, is the most studied and the most successful medications that had to try to promote spinal fusion in these patients with low bone mineral density. And lastly, conclusions. Basically, we know RA patients are challenging both in diagnosis and treatment. Vertical atlantoaxial instability and subaxial subluxation are the most common spinal pathologies. Neurological deficit should prompt urgent surgical intervention in these patients. And DMARD use has had a positive effect in decreasing the overall number of RA-related fusion across the state. That's the talk. Thank you.
Instrumentation and like now the only ones that I ever see are people who cannot tolerate DMARDs for some reason. They've only been on anti-inflammatories or something like that. And those are the few that we see. I was just going to make a comment about Scott Bowden. I'm sure most of you don't know who he is because he's sort of more of an elder statesman at this point, but still very active surgeon, but a real force of nature in spine. I mean, not only did he write some of these seminal papers in rheumatoid arthritis, he's out of the Emory Spine Group in Atlanta on the ortho side. They have a tremendous group, him, Rusty Rhodes, and a bunch of new guys. But he was also the guy who really brought BMP from like a experimental treatment in animals to humans. He did all of the seminal FDA work and literally brought it to fruition, all the original FDA trials. So really an incredible guy. Richard, you remember those days?
Alan, Roberto, can I make a comment?
Absolutely. Thank you for joining us, Roberto.
Just
I
from
hear you loud and clear.
Just from the historical perspective, I can tell you that what I'm talking about 30 years ago, some of the most rewarding cases, spine surgeries I have done have been for rheumatoid patients. And this was before the days of screws. So I remember that at that time I was taught that because we didn't have screws, that you had to include the occiput because the arch in these rheumatoid patients, the arch of C1 wasn't really strong enough frequently to hold the wires and so forth. But anyhow, the point is that I remember several of these patients that were just could hardly eat and could hardly move, and the symptoms were attributed for years to their rheumatoid arthritis, and it was thought to be due instead of myelopathy, which is what they had. I mean, a combination. But I remember some of these patients were really totally incapacitated in a wheelchair, couldn't eat because of their myelopathy, and for years it was attributed. Their deficits were attributed to the arthritis rather than to the myelopathy, and they had spectacular results in terms of improvement in the everyday activities and so forth. So very rewarding operation in those days when those patients were presented really very late. That's
Thank
all.
you.